Good afternoon, everybody. Happy Wednesday. I'm Dr. Reinhardt. I'm one of the directors of the Brooklyn Initiative to Develop Geriatrics Education, or BRIDGE program for short. It's a pleasure to welcome you today for this session on preventing falls in community dwelling older adults, something that's really near and dear to everyone on the BRIDGE team and geriatricians across the country and anyone with a grandparent. And also really important for improving outcomes and reducing cost of care for older patients. So this talk is part of a series of talks that are being supported as part of the BRIDGE program, in addition to our advanced certificate program in public health geriatrics in the School of Public Health. And we'll be using this talk as well to create an online learning module that'll be accessible for everyone at Downstate and the community for continuing education credit, and also just to learn about this important topic. So it's our pleasure today to welcome Dr. Patricia Dykes to speak on this really important fall prevention topic. Dr. Dykes is an associate professor of medicine at HMS and program director of research in the Center for Patient Safety Research and Practice in the Division of General Internal Medicine at Brigham and Women's Hospital. Her research aims to improve the quality and safety of care through patient and family engagements and clinical decision support. Since fall prevention requires a comprehensive assessment of risk factors and a tailored intervention plan, she has developed a clinical decision support for providers and patients to integrate fall prevention evidence into practice. To reduce falls and injuries in hospitals, she developed the Fall TIPS toolkit, which has been shown to reduce falls and fall-related injuries in hospitalized patients. It has been adopted as the standard of care at the Brigham and Women's Hospital, all Mass General hospitals, and over 250 hospitals in the United States, including the VA and Department of Defense facilities. To reduce falls for community dwelling older people, Dr. Dykes was a site PI for the NIA PCORI-funded STRIDE study, which integrated fall prevention evidence into primary care practices in 10 organizations across the US. She's currently developing fall prevention clinical decision support and a care plan collaboration tool to assist with primary care adoption of fall prevention evidence and best practices. And these tools will engage patients and families in the fall prevention process. She's also collaborating on several studies. She's the site PI for the NINR-funded CONCERN study using data science and machine learning approaches and EHR data to identify hospitalized patients at risk for deterioration. She's leading the development of electronic clinical quality measures for a CMS contract and was recently awarded a Gordon and Betty Moore Foundation Award to develop clinical decision support and e-com to improve the early detection of VTEs. So very impressive, Dr. Dykes. We're all looking forward to your talk. Thank you so much for coming. And the mic is all yours.
Thank you, Dr. Reinhardt, and good afternoon, everyone. Thank you for the opportunity to be here today virtually to talk about preventing falls in older adults. As you heard, fall prevention has long been a research interest of mine, but I would say in the last year, it's become personal for me since my 89-year-old mother had 2 serious falls that resulted in lower and upper limb fractures on both occasions. What I learned from this experience is that while the evidence behind fall prevention and community dwelling older adults is strong, its application is variable, and it really requires sustained partnerships between the patient, the family, and the care team. Before I get started, I want to acknowledge that this presentation is supported by a HRSA grant, that my research is supported by the National Institute of Aging and the Agency for Healthcare Research Quality, and I have no relevant relationships or commercial interests to disclose. So today I'm going to start by talking about the evidence for a fall prevention program in primary care. Then I'll use the National STRIDE study as one example of a program that was designed to systematically apply fall prevention evidence to practice. And then I'll conclude with a summary of barriers and facilitators to fall prevention in primary care and a discussion of some widely available resources to help overcome some of these challenges. So we're going to start with a few pre-questions. You can use your voting buttons to register your response. And the first question is, the 3-step fall prevention process is comprised of A, screening for fall risks, developing a tailored prevention plan, completing fall prevention documentation, or B, screening for fall risks, completing a fall prevention referral and initiating fall prevention follow-up, or C, screening for fall risks, developing a tailored prevention plan and ensuring consistent preventative interventions, or D, screening for high-risk medications, developing a tailored prevention plan, and developing a deprescribing regimen. So go ahead and use your voting buttons and you can select your response. Okay, so it looks like we had some responses for each of the answers, and I'm not going to give them to you because I'll talk about the answers in my presentation, and then you'll have a chance at the end to try again. Okay, and then the second question is, and it's hidden from my, an exercise program will prevent falls if it is A, designed to improve balance and strength, B, gets more challenging over time, C, is practiced for at least 50 hours, or D, all of the above. So use your voting buttons to make a selection. Okay, so looks like everyone chose one of these except for is practice at least 50 hours. So again, we'll talk about what the answer is a little bit later in my presentation, but thanks for participating. So at the end of this module, evidence for fall prevention in primary care, you'll be able to understand the problem of falls in community dwelling older adults and understand the evidence for preventing falls in community dwelling older adults. So all of you probably know that falls are a common and dreaded event by older people. They're associated with significant long-term consequences. More than 1 in 4 adults that's age 65 or older falls every year, and falls are the most common cause of hip fractures. Injuries from falls such as hip fractures can cause long-term functional impairment and even death. And despite the growing evidence that falls can be prevented, deaths from falls continue to rise, and fall-related deaths have doubled for US adults age 75 and older between 2000 and 2016. Falls can also result in a fear of falling that can then become a downward spiral of reduced mobility, leading to loss of function, and then further risk of falls. There's a great opportunity to make an impact in the area of fall prevention because the majority of falls are preventable. The fall risk factors and effective treatment strategies have been identified in many studies, and there's good evidence to support them. But the challenge now is to ensure that older adults at risk for falling receive appropriate interventions and referrals from their primary care providers. But despite recognizing the need, primary care providers do not generally ask older patients about falls and the associated risk factors as part of their routine assessment. And research has shown that less than half of older adults actually discuss their falls with their primary care providers. So there are many barriers to fall prevention in the context of a primary care visit. One is that you have limited time with a patient. It's difficult to integrate additional preventative and assessment planning into the visit. It's time consuming to follow through with patients to find out if they're actually following through with the recommendation. And then there's no standard strategy for intervening for patients with positive fall risk screens. I know in our healthcare system, every patient is asked screening questions by the medical assistant when they come into for a primary care visit, but it's really up to the individual clinician whether they actually address the fall risk in that visit. So research has demonstrated that fall prevention is a three-step process. It involves completing a risk assessment and then using the results of that assessment to develop a tailored or personalized prevention plan, and then consistently implementing the preventative strategies. And to do this requires engagement with the patient and family throughout all three steps to ensure that the patient and the family understand the risk factors and that they're involved in identifying interventions that are consistent with what matters to them. And so using the 4Ms framework of what matters, medication, mentation, and mobility can help with this. Knowing what matters to patients can help identify interventions that align with the patient's goals and preferences. They'll be more likely then to carry them out when they're at home living their lives. Helping patients understand how the medications that they're taking, the side effects may increase the risk for falls, can help with a partnership around deprescribing efforts. And regularly assessing for and treating dementia and depression will help older adults live independently longer, but will also prevent falls. And helping patients understand how good mobility will help them to maintain function and to continue to do what matters most longer can help with getting patients to agree to setting mobility goals and plans to achieve them. The risk factors for falls and preventative interventions are well established. They're frequently cited in the literature. Over the next few minutes, I'm going to review the most common risk factors for falls for older people living in the community. We'll also talk about the preventative interventions and how to focus on patient engagement using the 4Ms. So we know that fall risk increases with polypharmacy. In most studies, polypharmacy is defined as 4 or more drugs. The reality is that many older adults who are seen in primary care are on at least 4 medications, and this increases their risk for falls. The CDC recommends the safe medication review framework, whereby you first screen for medications that might increase risk. You assess the patient to best manage their health conditions. You use that to formulate the patient's medication plan, and then you educate the patient and caregiver about medication changes and fall prevention strategies. There have been many studies that have highlighted the linkage of certain medications to increase fall risk and the importance of identifying these fall risk increasing drugs or FRIDs, and then engaging the patient in a deprescribing plan if possible. And on the right of this slide, you can see the most common FRIDs that you'll see cited in the literature. A deprescribing plan includes first stopping meds when that's possible, but we know this is tricky, especially when patients have been taking certain FRIDs like benzos for years since they were in their 50s. And so here's where talking about the meds in terms of what's really important to the patient and how the medication plan can be revised to support their wishes and goals. The medication plan can also include switching to a safer alternative or reducing the dosage of the medication to the lowest effective dose. Another risk factor for falls that can be tricky to treat is postural hypertension. So by definition, postural hypertension is a drop in systolic blood pressure of greater than 20 millimeters of mercury, or in diastolic blood pressure of greater than 10, or they're experiencing lightheadedness or dizziness, which is considered abnormal. Interventions that can help, including teaching patients self-management skills like increasing their fluid intake, reducing consumption of caffeinated beverages, making slow position changes. So when they're first getting up in the morning, getting up slowly and gradually, and wearing elastic stockings. And then continuing to monitor the symptoms in response to their self-management plan, and then further evaluating for medication changes or referrals if needed. Visual impairment also increases risk for falls. In terms of the assessment, it's important to encourage regular eye exams and to ask patients about corrective lenses. We counsel patients about the importance of the regular eye exams, about the importance of not wearing multifocal lenses, for example, outdoors or on uneven surfaces. That's a very common way that people fall, or reason for people to fall. And then, of course, making referrals as needed. Problems with the feet and footwear can also increase risk for falls. As part of the annual assessment, look for chronic or new foot problems, nail problems, which can lead to unsteadiness. Also note the footwear that the patient came in with, and then you can use your observation as the basis for your recommendations. Inadequate vitamin D intake can lead to impaired muscle strength and neuromuscular function, can also decrease bone mineral density, which can increase the chances of instability and the risk for fracture with a fall. And so the evidence suggests that vitamin D deficiency is very common in older people, particularly in the Northeast, that this deficiency impairs muscle strength and neuromuscular function, that vitamin D it's effective for fall prevention, and this is distinct from its effect on bone health. And the benefit is even in older persons who have a normal serum vitamin D level. And so the recommendation is that we should provide a recommendation for people to take vitamin D supplements unless it's contraindicated. So osteoporosis and osteopenia also place people at risk for falls. And so as part of your assessment, you review the FRAX score. You can calculate a FRAX score. This can be done easily. There's many tools that will help you do this online. But if you don't have time to calculate, oops, sorry. But it's really, you might not have time to do a FRAX score in the context of a visit. And so really just watching the patient, walking into the exam room and seeing how steady they are. Are they using an assistive device? Are they using it properly? So those kinds of observations can also help with assessing their safety. So home hazards are also a common reason why older people fall in their homes. It's rarely possible to do a thorough home assessment while you're having a conversation with the patient, because the patients are often unaware of the hazards that exist in their home, or they might be aware of them, but they're not willing to address them. So for example, during the STRIDE study, the nurse falls care managers would very often say to the patient, oh, you really shouldn't have these scatter rugs. Should we pick them up? No, I don't want I like my scatter rugs. It makes my house feel like a home. And so, coming up with other recommendations like taping the rugs down are sort of a secondary recommendation. So here it really helps to use some patient and family home hazard risk assessment tools. There's a really good one on the STEADY website. We'll be talking about STEADY tools later. Encouraging the patient and involved family members to use the assessment and then to make the changes to help them realize what matters most and help them to explore the barriers, including affordability of the recommendations. So fall risk factors of weakness, gait and balance concerns, these are very common in older people. Conducting an assessment like the short physical performance battery can help you identify and quantify gait and balance needs. There's many tools online to help you do this. So again, you may not have time to do this during a visit. So again, watching the patient walk, if they're stable, and whether or not they're using a walking aid, and use that to inform the recommendations. There are many different options for exercise. So during the pandemic, we, a lot of the community-based exercise programs were not running. And so they're starting to pick up again. But the problem with home exercise programs is that they start, they run, and then they end. And, I think that our messaging to patients has to be that they need to exercise every day. And so that's even when the community exercise program isn't running. And so to do that, we really need to, in addition to recommending community exercise where appropriate, we need to be recommending home exercise. An exercise program, so based on the evidence, an exercise program will prevent falls if it meets all three of these criteria. So it's designed to improve balance and strength. It's progressive, so it gets more challenging over time, and it's practiced for at least 50 hours. So here, that means if they're taking a 1-hour class 3 times a week, they need to do it for 4 months, or if they're doing a 1-hour class 2 times a week for 6 months. And so by adding on the days when they're not going to class, some safe exercises will really help with them getting the benefit of that exercise. And so now we've reviewed the risk factors for falls in community dwelling older adults and the evidence-based interventions. Now I'm going to talk about the STRIDE study, which was an NIA PCORI funded pragmatic trial. It was conducted across the United States to try to integrate fall prevention evidence into primary care practices. And so our objectives are to explore strategies for applying fall prevention evidence in primary care practices, and to understand the findings and lessons learned from the STRIDE study. So first, a little bit about the STRIDE team. So we had 3 overall PIs on the STRIDE study. One was Shally Basheen from Partners, Tom Gill from Yale, and David Rubin from UCLA. And we were 10 clinical sites, trial sites across the US, which encompassed 86 primary care practices. I was the site PI for the Partners STRIDE team. Right now, Partners has changed their name. We're Mass General Brigham. And our data coordinating center was Yale. So what was the STRIDE intervention? So we had a co-management model whereby we had a falls care manager that partnered with the primary care provider in all of the practices. There was at least one in each of the geographical sites. They completed an in-depth fall risk assessment on the day when the patient went to see their primary care provider. And so based on that assessment, they worked with the patient to develop an initial plan of care that was focused on their personal risk factors. And once that plan was approved, they had a call with the provider, and then based on any suggestions or refinements, they then worked with the patient to implement it. And we followed the patient over a period of 2 years. This is a picture of the patient-centered fall prevention care plan. And so on the left-hand side, these are the common risk factors for falls in the community. And so this was the template that the nurses would use, the falls care managers would use with the patient to find out, to first identify with them the risk factors that were present for them, and then to work with them on identifying which of the risk factors were a priority for them. And we encourage the patients to pick, when they had multiple risk factors, to try to work on at least 3. This is the STRIDE patient follow-up structure. So the initial visit was done when the patient was having an annual wellness visit or an annual visit. And at that point, that's when the nurse did the initial full fall risk assessment. Once that was approved by the PCP, the nurse called the patient and did some follow-up, talked about what were the steps they were going to take to implement the plan. And then at 3 to 4 months, there was a follow-up call to see how they were doing. There was a 6-month visit in the PCP office, or they could get a home visit from the nurse if they preferred that. At 9 months, there was a follow-up call, and then the year two visit was the end of their follow-up period. So our inclusion criteria: patients had to be at least 70 years old. They had to fail the risk screener. So that meant they had to say yes to one or more of the following questions. Have you fallen and hurt yourself in the past year? Have you fallen 2 or more times in the last year? Are you afraid that you might fall because of balance or walking problems? The exclusion criteria that we had are that the patient is enrolled in hospice, that they reside in a nursing home, that they weren't capable of providing informed consent, and they didn't have a proxy, and the patient didn't speak either English or Spanish. And so we really tried to have very few criteria because we wanted the intervention to be generalizable. Our STRIDE research question was, can redesigning primary care, medical practices, and engaging patients reduce serious fall-related injuries and improve other outcomes within real clinical care? And so our primary outcome for the STRIDE study was serious fall-related injuries, and that was operationalized as injuries that led to medical attention, including non-vertebral fractures, joint dislocation, head injuries, lacerations, and other major sequelae. And these were all adjudicated using electronic medical records. And then our secondary outcome was all injurious falls, and these were patient reported. So all falls regardless of injury. And we also measured well-being, fall efficacy, anxiety, depressive symptoms, physical function, and disability. So what did we find? So the demographics of the patients that participated in our study, we had about 5,400 patients from 86 clinical practices. The mean age was 80. 62% of our patients were women, over 90% white. Most of them had a college education or higher. And about close to 40% had a fall with an injury during the previous year. So that was self-reported based on their screening. And about 35% had 2 or more falls during the previous year. I talked about the different risk factors, and in our last section, the most commonly identified risk factors in our cohort were problems with strength, gait, or balance, osteoporosis or vitamin D deficiency, and vision impairment. So for our primary outcome, which was first adjudicated serious fall event, we saw an 8% reduction, which was not statistically significant. So there were 4.9 events per 1,000 person per 100 person years of follow-up in the intervention group, and 5.3 events per 100 person year in the control group. Our secondary outcome of first participant reported injury from a fall, we saw a 10% reduction. That was significant. In the intervention group, there were 25.6 events per 100 person years of follow-up, and in the control, 28.6 events per 100 person years. So STRIDE was a pragmatic trial. Our patients and providers faced all of the challenges that all patients and providers face when trying to implement evidence-based care, including barriers to follow-up. In 2015, which was our first intervention year, I remember we had 108 inches of snow in Boston. In 2017, there was a Hurricane Harvey in Galveston, Texas, that made it very difficult. Both of these events made it very difficult for patients to come in and very difficult for providers to follow up. We did see a decrease of 8%. That wasn't significant. So despite the fact that falls are increasing in older adults, based on this study, it appears that the rate of injuries is down. So STRIDE, we powered STRIDE based on injury rates that were reported in the literature. We had hypothesized a serious injury rate of 20% in the control cohort, but the actual rate was 50% lower at 10%. We did measures that reduce risk in the setting of a clinical trial, maybe are less effective when we face real world challenges. Some of the things that we saw a lot in STRIDE were difficulties with patients securing transportation. The cost of follow-up care, sometimes even the copay was a barrier to people following up. Behavioral interventions are not monitored, so we tried very hard to get people to enroll in exercise programs, to do home exercise, and of course it's self-report and was not monitored. We did use motivational interviewing. We did try to engage patients in the assessment, in the risk assessment, and developing the personalized plan. This did allow patients to select interventions that they're most willing to implement, but sometimes the ones that people are most willing to implement are not the ones that would potentially make the most difference. Improving quality of care for falls may not be sufficient to reduce serious fall injuries. So to achieve a larger reduction in serious fall injuries, we think that improvement is needed in the delivery and access to the key interventions like exercise, and really making that systematic for older people. So now we've talked about the risk factors, the evidence-based interventions in the STRIDE study, which we tried to integrate fall prevention evidence into primary care practices in that study. As you saw, we had some success, but there's much more work that needs to be done in this regard. In the final section, we're going to talk about fall prevention barriers and facilitators, and specifically about the resources that are widely available for falls in primary care settings. So at the end of this session, you will be able to understand common barriers and facilitators to integrating fall prevention evidence into primary care practice, and identifying resources available for preventing falls in community dwelling older adults. And before I go through the content, we have another question for you. So the question is, common barriers to community-based fall prevention include A, provider perceptions that falls in community dwelling older adults are inevitable. B, patient ambivalence about personal risk for falls. C, limited time to address fall prevention during a busy office visit. Or D, all of the above. So use your voting buttons to register your response. Okay, so everyone said all the above and everyone is right. So that one, we got 100% on the pre-test. So we won't need to do that one as a post-test. Thank you for participating. Okay, so over the past, so now we're going to talk about barriers and facilitators to fall prevention in primary care. Over the past year and a half, our team has completed interviews, a series of interviews with primary care providers, patients, and staff to explore some of the barriers and challenges and facilitators to fall prevention in primary care. And we conducted these at the Mass General Brigham Primary Care Practices. Today, I'm going to focus on the themes that we heard from the providers. And so namely, we heard that the intervention must not add time to existing workflow. So we heard a time and time again about, how difficult it is to just address, what the patient came in for, let alone adding additional screenings and care planning and fall prevention planning. We heard that standardized resources to reference and share with patients during the visit would be helpful, that a lot of providers are aware that there are resources on the internet that are available for helping patients with fall prevention, but they really don't have time to be searching for those during a visit. We heard a lot about the need to overcome staff and clinician nihilism and ageism. So there is a belief in many providers and staff that older people are going to fall and there's not too much we can do about it. And so that belief is there despite the fact that we do have evidence that falls can be prevented. We also heard that talking points to resolve patient ambivalence, highlighting the reasons for change, would be helpful, and to have those, at their fingertips while they're seeing patients. That systematic communication between care team members and patients and families was needed, and that it would be helpful to have evidence-based safe exercise recommendations. We heard from, again and again, from providers that, for some patients, they're actually afraid to prescribe exercise because they're afraid that while the patient's exercising, that they'll fall and have a fracture. And so, making recommendations about what exercises are safe would be really helpful. So over the next couple of minutes, I'm going to highlight some of the resources that are widely available to address fall prevention in the context of a primary care visit. I understand all of you have access to these slides. It includes all the links and resources that address the major risks for falls in community dwelling older adults. The first resource that we'll talk about is the STRIDE website. So all of the resources that were used to integrate fall prevention evidence into primary care practices are available from the STRIDE website. And here is the link is at the bottom of the slide. So as an example, all of our protocols, so each of the risk factors, the major risk factors for falls, has a protocol for how to address it in primary care in a scientific, evidence-based way. The protocols are open access. They're found on the website. And so this is an example of the postural hypertension protocol. And then we also have up there the care plan, which we talked about earlier, that template. In STRIDE, for patient-facing tools, we used a lot of the patient handouts from the STEADY toolkit. So STEADY stands for Stopping Elderly Accidents, Deaths, and Injuries. And they have a whole host of tools for patients that are very patient-friendly. The language is appropriate. They're in English and Spanish. So just here you can see that there's one for staying independent. So are you at risk for falls? And so this is a really nice brochure that allows patients to do their own assessment for risks. And that could provide a good baseline for the discussion they have with their providers and primary care team when they come in. The check for safety, doing the home evaluation, there's one for postural hypertension, and then again, what can you do to prevent falls? This is a screenshot from study, so it shows you all the different types of resources that are there. So there are some clinical resources for the primary care team. There's also some content for inpatient care, outpatient care. There's some deprescribing information under pharmacist care. We talked a little bit already about the patient and caregiver resources. There's also provider training and education and videos, and then some links that go out to some other evidence-based websites and information. Currently, our team is funded by the National Institute of Aging to develop personalized exercise prescriptions for older adults. So all of our exercise resources that we're developing, including simple videos, handouts, are based on the evidence-based Otago program, and they can be found on the Homestrong website. The National Council on Aging also has links to an array of fall prevention resources and evidence-based exercises that can be used. The Elder Care Locator, they have a website, but they also have an 800 number that can be used to access community-based exercises and fall prevention programs across the country. The National Institute of Aging has web-based exercise programs on their website. And for resources related to FRIDS, fall risk increasing drugs, we recommend the deprescribing.org website. It has a host of tools that assist providers and patients with deprescribing and with safe medication practices. Here's some examples. So this is a deprescribing algorithm. And then we also have, they also have tools that you can use with the patient. So this is a monthly taping calendar that you can use with the patient to help them know how much of the drug they need to take every day. So here is a postural hypertension brochure. This is available on the study website. On the STRIDE website, we have some information about feet and footwear that are available for patients. And STEADY has the check for safety. I talked about that. So that is a good brochure for patients to use to do their, and with family members to evaluate how safe their home is. And then on the STRIDE website, we do have some information on osteoporosis. Our team is currently working on some additional patient-friendly resources that on this topic for an ARC-funded study that we're working on. And then STRIDE also has some vision-related resources that are from the CDC. So the bottom line is that there are a lot of evidence-based resources that can be used in primary care to integrate fall prevention evidence into practice. I focused mainly on three websites, so STRIDE, STEADY, and deprescribing.org, because I know that it takes time for primary care providers and staff to get to know these resources and then to identify the tools that you're comfortable using with your patients. Our team is working on ways to integrate these resources into the electronic health record, so all of them can be accessed in the context of a visit. But in the meanwhile, I think it's worth spending time identifying your favorite resources, saving them in a place so that you can access them while you're seeing patients. So just to wrap up, in summary, so falls in community dwelling older adults are a challenge, but they are preventable. Fall prevention is a continuous three-step process. It involves engaging patients and family in risk assessment, and then taking the results of that risk assessment to develop a personalized fall prevention plan, and then having the right amount of follow-up to ensure that the patient's able to do the lifestyle changes to implement the plan. There are evidence-based resources to support primary care providers and patients in the three-step fall prevention process. So I started my presentation by mentioning my 89-year-old mother who had two very serious falls in the last year, both resulting in upper and lower limb fractures. Most recent fall was this past March. By partnering with her primary care team and with me as her advocate, my mother has received excellent fall recovery and prevention care, focusing on in her case, our focus was exercise and bone health. In June, my mother was discharged from home PT after she shared with her therapist that she had walked over a mile with her rolling walker to go to church and then out for dinner with my dad and my sister. So the therapist could see that she was clearly no longer homebound. She now walks across the street to get physical therapy a few times a week. My mom is living as she wishes in an apartment in Boston with my dad. She sees the connection, a clear connection between her daily and very vigorous exercise and her ability to remain safely in the community, which is where she wants to live. So my hope is that in the future, all older adults will routinely participate in assessing their fall risks and developing a personalized fall prevention plan with their primary care team, and this will help them to continue to do the things in life that are most important to them. So with that, I will wrap up with the post questions, just the ones where everyone didn't get the right answer on the first try, and then we have plenty of time for discussion. So the first question, common barriers to community-based fall prevention include A, providers' perceptions that falls in community dwelling older adults are inevitable. B, patient ambivalence about their personal risk for falls. C, limited time to address fall prevention during a busy office visit, or D, all of the above. So use your voting buttons. Okay, so the answer is D, all of the above, and just about everybody got it right. All right, the next question is about the three-step fall prevention process. So the three-step fall prevention process is comprised of A, screening for fall risks, developing a tailored prevention plan, completing the fall prevention documentation. B, screening for fall risks, completing fall prevention referral, and initiating fall prevention follow-up. C, screening for fall risks, developing a tailored prevention plan, ensuring consistent preventative interventions, or D, screening for high-risk medications, developing a tailored prevention plan, and developing a de-prescribing regimen. So use your voting buttons. Okay, so the correct answer is C, and most of you said C. So with the three-step fall prevention process, it's assessment, tailored planning. So you do the assessment to find out what risk factors exist, because with fall prevention, the plan has to be tailored. It's you have to look at, because interventions for a person with a cognitive issue are different than a person with a gait issue. So you really have to do the assessment and see what is it that is present for each individual patient. And then based on that assessment, you develop a personalized or tailored plan. And then, you can do all the assessment and planning that you want, but unless you actually oversee that it's done, that the patient, if they don't actually do the plan, then it's not going to make a difference. So then the third one is actually consistent preventative intervention. So the person changing their lifestyle to address the risk factors. And the third one, everyone got right the first time. So about, oh, actually, maybe it was the first one. Maybe we should do this one again. I think, okay, so an exercise program will prevent falls if it is A, designed to improve balance and strength, B, gets more challenging over time, C, is practiced for at least 50 hours, and D, all of the above. So use your voting buttons to register your response. Okay, so the answer is D, all of the above. So the three, A, B, and C are, components of a successful or an evidence-based exercise program, but you need to have all three. So that's the idea, is that, you need exercise programs need to improve balance and strength. They have to get more challenging over time as the patient, gets familiar with the exercises and they're able to do them more easily. They should increase the number of sets or the length of time they're doing them. And then it needs to be practiced for at least 50 hours before you actually see the benefit to fall prevention. Okay, so now we can take some time for questions. Thank you so much for your attention.